Dream machine. DICOM, HL7, I18 in the snap. We're building the future, never looking back.
Everybody talks about interoperability, but after decades of HL7, DICOM, and now FHIR, why does healthcare still struggle to connect the dots? In this episode of Imaging Informatics Unplugged, we go beyond the buzzwords and vendor slide decks to ask why is interoperability still broken and how do we fix it? To help me unpack that, I'm joined by Toni Skokovic, a health tech veteran with 25 years of experience leading product strategy and commercialization for companies like Merge Healthcare, Interface Wear, and Element Blue. Today, through his company, YourRevenuePlan, Toni helps health tech innovators to translate technical capabilities into scalable growth, blending deep expertise in diagnostic imaging, automation, infrastructure, and sales enablement. Now, in this conversation, we dig into why integration is not the same as interoperability, how automation without alignment actually slows adoption, what agentic AI can realistically solve, and where the hype outpaces reality. And we look at how both providers and vendors need to rethink their approach, not just at go live, but throughout the real world outcomes. This isn't about abstract frameworks. It's about solving real bottlenecks, improving workflows, and making interoperability actually work. And if this topic hits close to home, quick heads up, I'm running a one-day live course. This is EIB 110 Enterprise Imaging for Business Professionals, split into 2 half-day sessions on September 17th and 18th. It's ideal for anyone in imaging IT, clinical operations, or the vendor world that wants to connect the dots between standard systems and strategy. So you can learn more and register at learn.nagelsconsulting.com. And with all that said, let's jump in.
Welcome back to Imaging Informatics Unplugged. And today we have Toni Skokovic. And Toni, thank you very much for joining today. As an industry as a whole, we get distracted a lot of times with what is the latest and greatest, whether it's new technology or it's new technology that's trying to address interoperability based on, pre-existing standards. And we lose out on, when we take a step back, there still is functional interoperability challenges across the board. Vendor A doesn't still like to talk to vendor B, despite very well established and mature standards. I thought maybe we could start things out. We've had HL7 and DICOM and FHIR for a number of years. We've moved to RESTful services. So in your opinion, your thoughts around this, why do you feel that interoperability is still such a challenge in healthcare?
Well, Jason, thank you for having me. I think this is a very important conversation, and thank you for establishing this forum and library of conversations on interoperability. And I think it's still very much a pertinent topic why interoperability is a challenge. And the reason is that when we typically talk about interoperability, providers or vendors alike, doesn't matter, that conversation almost automatically gets narrowed down to connection standards and technical aspects. And as we know from broader world of business and use of technology in business, successful adoption of any technical solution rests on technology, people, and processes. And I feel like in healthcare, we still haven't gotten into a cadence of change management and the process approach, skill development with people, and that being orchestrated in concert with the innovation in technology and standards. And no better example than introduction of HL7 FHIR and that whole transition to API-based integrations, which came naturally about, I would say, 10, 15 years ago with proliferation of web apps and web platforms. And we have gotten that right because it is the best way to create event-driven integration and number of benefits in terms of loose coupling of systems and a lot of techno jargon.
Mm-hmm.
But a simple challenge that you would see in particularly ambulatory practices that you had them spend not inconsiderable amount of time developing expertise for their integration analysts to do data mapping in HL7 version 2 world and get proficient at that. And, no better example than success of CorePoint, for example, with their easy to use tools for non-technical people at that point in time. And then just as most organizations have figured out how to budget for that headcount and how to sustain it in terms of just onboarding of new clinical partners and so forth, we have presented them with the challenge of APIs and orchestrating APIs. And that's a whole different game, as we know from technology world, is you need different types of resources, you need different type of project discipline, you need different type of infrastructure stance. So to me, I think we're still at the same point of having that as a challenge because we fail to triangulate between infrastructure, people skills and process, and technology. So we keep advancing one of those edges without necessarily pulling the other two together. And this is where you hear, especially with FHIR, it's like cores that you hear is, oh, people have old way of thinking and all those kind of things. But, in the early days of FHIR, I heard a number of times from providers. So you're telling me that I need to go through all this expense and all this training and all this migration of integration platform to actually do what I can do today, which is to accept orders and register them in my system and deliver results back. And the answer was, well, kind of. And I think that there's a lot of ground that is not necessarily difficult to make up, but it requires a little bit more attention and focus, both from standards development organizations and then various constituents, particularly vendors and providers. Everyone has a role to play in delivering it.
So you're striking on something here. There's a myriad of resources that are deployed and used when we're implementing a new solution. So you've got the back end building out the APIs or making sure that the mappings are correct. And so that takes a specific, skill set that we're going to fill, and we're going to make sure that that is filled. I often find that the implementation is done, a project is considered complete, the box is checked, and now the vendor walks away, the provider is happy with the fact that now they have implemented the solution. But the idea of adoption really doesn't get talked a lot about in this industry. And so now you have users that have an impairment because, yes, you have the Ferrari that has all the bells and whistles. They might be simple bells and whistles to push. They're just unaware that some of those options are even there. And I wanted to get your thoughts on that and what we can do to help bridge that gap.
Yeah, I love your analogy because it's equivalent to buying a Ferrari and deciding that you're going to win a race championship, right? And not considering the cost of insurance, not considering access to the racetrack, not considering cost of gas, which Ferraris do not take irregular gas and not a small amount of it, and then maintenance and cost, right? So I think that's usually in business we call this total cost of ownership, but it goes well beyond that. It goes through measuring any IT project through operational objectives, right? I don't want to say business because in healthcare we don't necessarily talk about business indicators, maybe in the US, but elsewhere we want to have different measures. But operationally, in terms of clinical benefits, is that integration producing the throughput benefits that it was supposed to? Because sometimes we suffer from that, silver bullet thinking that if we only replaced integration engine, then it will solve all of our problems. And the problem that it typically solves is the aging out of your resident experts. But it doesn't move you ahead, but you spend considerable amount of money and energy on doing that replacement. So it is more about thinking in more agile fashion, because what you described is very typical, very waterfall. We're going to identify, and then we're going to map, then we're going to do this. And I think it is much more true now than it used to be, maybe even 10 years ago, is that we had tool sets and technologies and access to information that allows us to be more selective and flexible, in a sense that, if patient intake is a challenge, if patient intake is a operational bottleneck, then we know that is the bottleneck that can be solved, and it doesn't require a wholesale replacement of anything. You could keep your enterprise integration engine, you can keep your EHR, and don't touch it. There's ways, and this is the benefit of all the work that was done. I don't want to say that we haven't validated all the standards work. There's a lot of work that was done, and it's foundational. So you will get a CDA from any EHR. You have to. They all talk, at least HL7 version 2. All imaging systems do deliver DICOM. So you have a lot of foundational information that you can now orchestrate, and we have tools that are powerful enough and AI assisted to flex to that custom, one-off. This practice will send me a fax, or I could do that with some of the automation tools. This practice is going to send me HL7 version 2. This practice has APIs, great, and then bring all those in without touching too much infrastructure. We now have ability to do that, but now we need to change our project thinking to going basically hunting and focusing on critical operational bottlenecks and optimizing for that, expanding, scaling, and then moving down the chain. So basically really looking at a patient journey, both in terms of efficiency and experience for both patient and then care providers, because we are all aware of the burnout and resource constraints and availability, all those kind of things. And we do have tooling now that can leverage all this foundational technology to drive outcomes. But we have to, interoperability challenge is not about integration points. It's about integration points, having the infrastructure to run on it, and then having orchestration, however you do it. I wouldn't recommend hard coding or using workflow engines of the 90s, but rather going into agentic automation on top of all of those components to actually have a learning, evolving system that can improve throughput, manage everybody's workload better, and all those kind of things. And since we're talking interoperability, I'm going to say something controversial, is that you see a lot of vendors, EHR systems or PAC systems or lab systems or whatever, introducing AI workflow enhancement. That's not going to get us to that end to end, because you will always have multiple systems. You'll have external entities when you talk about care coordination and transfer of care and all those kind of things. So here, providers have to start thinking more in terms of, yes, we have the 3-year, 5-year strategy, but we want to operate in 6-month increments, and we can be more agile. And that's a big shift from, as you described, we're going to replace the integration engine first, then we're going to look at storage, then we're going to do packs, and all of these are 2, 3, 4-year projects that sort of age out when they go live. They're already sort of old technology, old solutions and healthcare is evolving much faster. So providers need to change their thinking, and then, conversely, vendors need to adjust to that and focus on more evolutionary than revolutionary. Like our product is better than the others, just replace it and it will solve everything, which you still hear from salespeople globally, right?
So you mentioned agentic, and I was, if you went back in time and looked at all the programs from RSNA and SIM over the years, I find there's waves of buzzwords that come around. So like 2013, it was all about dose. And then a few years later, it's all about moving to the cloud. And then a few years later, we've got AI. And now we've got more of a niche sliver of AI where we're talking about agentic AI. And then if you look back, to varying degrees, those problems have and have not been addressed. And you still have, at least in Canada, lack of comprehensive dose knowledge for a patient's history. There's varying degrees of cloud, and we end up getting caught up in the hype cycle of what's next. So now the focus is on agentic AI. This is a bit of a two-part question. One is where do you see AI, and specifically the idea of getting automated and agentic AI helping either solve or contribute to some of these interoperability challenges, and then what are your thoughts around this hype cycle that we see? Is now we're focused on agentic AI. Who knows what the buzz will be in a couple of years from now, and we still have somewhat some foundational challenges that are present for these buzzwords that have come up.
Well, I'll replay a conversation from 20 years ago. Just show how we're still doing the same thing. And at this point in time, a big thing was in imaging, the delivery of advanced post-processing, especially on PET-CT, MR, CTs, and so forth, right? And so that was a big thing. This was back in the day when multi-slice CT sales were exploding and imaging was growing in the US and all those kind of things. And at that point in time, talking to anyone but people involved in a care delivery workflow, radiologists and technologists, it was all about, we need to have it in real time, and then there was like a massive spend on hardware and a lot of things. But what end users wanted is just to have relevant data ready when they get to it. And I think that's important. But that doesn't mean that it needs to be real time, and it doesn't mean that it needs to have, high-end network throughout the facility. It doesn't mean that it needs to have a $45,000 workstation at every desk and all that type of stuff, right? Which are all good sellable points. And that is also important to note, is that these are very discrete sellable items by number of vendors, and they also appear as a solution. But the solution was to actually get smarter with the workflow, and I think we have seen that repeat itself with the rise of tomosynthesis and mammography imaging, and now with CAD, and then now AI, diagnostic AI, and like where it happens and how. And so where I'm going with this is that we are always trying to sort of look at what we have in the toolbox and then figure out how to sort of call everything a nail or a screw or a bolt, depending on what we have in our hand. Much more holistic approach is the only way to do that, because and this is where AI fits. AI fits in delivering everyone on a continuum of care information that's required in context. Going back to maybe concept we call semantic interoperability, to bring it back. And so this was not necessarily possible in a way that we have. And there is always danger, hype cycle, cloud and AI, and who knows what next RSNA HIM cycle is going to bring us. But the point is that agentic and robotic AI automation specifically has ability to do that orchestration that is really rooted in that particular practice, ambulatory or acute, workflow and set of rules, right? Because especially specialty hospitals specialize in specific diagnostic area and specific demographic, like pediatric or senior or whatever. And then their workflow is going to be very specific to what they're optimizing their operations for. They're not going to optimize it for everything. No hospital does. They specialize in, stroke or cancer care or cardiac or whatever. And so the benefit of AI, agentic or otherwise, is in that learning workflow that is specific to the facility, specific to their capacity in terms of specialists and technologists and non-clinical staff, and then helping them go through their work list. I mean, best example is you go into any IT department and you look at their whiteboard and they'll have 20 plus items as a backlog. So where AI helps very simply is help them go faster through their backlog. It's not about replacing people. And likewise with physicians. I spent some time in the emergency room with a family member just recently. And, emergency room, you sit around and wait for a long time because thankfully it wasn't that critical of a situation, right? You don't want to be center of attention in the emergency room, right? So out of that boredom, I decided to time how much time is being spent behind screens by clinicians. And it was 40 to 60%. And most of the time was not charting, it was looking stuff up.
Yeah.
So going back to that conversation with radiologist 20 years ago, his concern wasn't that it needs to be fast. No, his concern, number one, was that it needs to be there when he's ready to do his 70-second read of a complex study, right? And so when we talk about possibilities for improvement, and this is a hospital, by the way, that has just gone through a very publicly lauded go live with one of the major EMRs, and you can imagine who it is and all those kind of things. And 4 months later, the emergency room staff is basically searching, looking up. So imagine a situation where you can actually take 10% of their time, give it back to them by curating the right clinical content and summaries. And you can also start imagining this wonderful world where you can query, in Ontario in particular, these central repositories that have all this information on behalf of a physician, cross-reference it to the main complaint, secondary complaint in an existing charting system, and then filter what's relevant clinical history over 3, 4, 5 years that we have, right? And I think those are possibilities that are more about, the 3 areas that are, of course, intake, referral, optimization, scheduling resources, all those kind of things. That goes without saying. But to me, one of the biggest things is that completing a chart and a patient history for physicians and taking them out of the work, them or their assistants out of the work of gathering that. Second part to that is go also say, okay, this patient needs to have hip replacement. Well, what are all the pre-op exams and prep that need to happen? Send them, have that ready. When they're ready, schedule an appointment, have those results and all those kind of things. And for all this to happen, we have tools. It's just, it's now connecting the dots, because agentic is being thrown out for everything. And it's very important to, much like for HL7, what HL7 FHIR is good for and where should you leave V2 alone, it requires a contextual conversation in terms of workflow and desired outcomes, right? And that's one of the things we started this conversation about. Why are we still having these challenges? Because we have failed to define why we're doing interoperability in most cases, and then we definitely forget, and I know this from my days at selling integration engine, but we fail to go back and measure that impact. Was this $500,000 project all in worth the 6 months it took or 8 months it took? And like you hear harrowing things like, okay, well, we integrated with our EMR and it only took us 24 weeks, and that's somehow a success. and if you think about 25 weeks, a number of encounters, a number of patients, and if you want to think about in terms of billing, or if you want to think about in terms of legal liability for not having the right information or cost, it's staggering. You have basically invalidated a project with the length of it in a way.
I'm curious, like from your experience when you were on the vendor side and you were, trying to sell interoperability integration tools to providers. One of the challenges I find is this is a hard sell sometimes. The people that are making the decisions, they don't necessarily understand the nuances and the challenges around interoperability and everything that we're talking about. There was a great talk at SIM that was about CDS hooks and how you can use FHIR and some other RESTful options for clinical decision support and like hooks, and they could be all customized. So in Ontario or in Canada, you could potentially, as you're ordering it, be alerted that the patient has received outside imaging from across the street. And maybe that would prevent the opportunity of imaging that patient a second time. But that's a hard sell because there's other things that need to be addressed beyond these types of, as you're mentioning, the time that you're spending on that. No one's going to argue with the fact that clinical users shouldn't be looking at a computer screen less. However, sometimes the path to get there is a bit tricky to explain. So what's your experience, and what do you recommend for folks that are trying to nuance that to users?
So I think that this goes into multiple areas, right? And I think that this is where at its base, integration technology is a commoditized sale. At this stage, field is, everyone can do web services, everyone can do APIs, everyone supports HL7 version 2. Hyperscalers sort of throw it in if you subscribe to a certain level of their sandbox. So you have to become a truly committed to solution and consultative selling. And who you sell to has to change, right? And that has evolved quite substantially over the last couple of decades that I've been involved in businesses that at a specific time, IT has had a lot of independence in terms of deciding on clinical systems and how the clinical systems deployment goes. And so before we go into what providers have to sort of shift in terms of their thinking, and they're already pushed there because people that own budgets and that own KPIs, however they're styled, are head of clinical departments. They're not heads of shared services, but our entire vendor space has been optimized over the years, and maybe through lack of fresh blood from sales and marketing perspective, like we have a lot of people that have done nothing but specific type of healthcare sales for decades, have been optimized to sell to IT buyer, mid-level buyer that has approval for a budget. In a lot of cases, they're not 100% clear as to what are the operational objectives of doing that project. And that's not the conversation, because now you're in, I need, HL7 FHIR support for this version and version 2, and it needs to run in the cloud, support containers, whatever. Like we have all seen. And in that scenario, your sale is then feature function, and you have to find a way to talk to people that are driving the agenda as to why this is a conversation to begin with. And some vendors have managed to successfully do that, and those are the ones that you usually see at the top of class ranking, and you usually see in large enterprise projects. But it's a certain level of discipline that's different from what we have been doing as an industry for a long time, right? Because you're going in to sell integration engine, and that's all you care, or you're just going to sell departmental system, that's all you care, and then integration becomes this auxiliary thing that a couple of guys in the corner go in and dig their hands, elbows deep into some JavaScript code or whatever, and sort of divine something out, and we hope we sort of break even on it. Whereas this has to be essential pieces, how this works together with what you need to do. And that's the conversation that vendors absolutely have to commit to, for selfish reason of that will drive into bigger projects, better margin accounts, right? That's the benefit. On the flip side, healthcare providers do need to integrate that conversations, and they are, just because of the budget discipline, right? Because it's like, we've tried replacing integration engine. We have outsourced interfacing to the experts, and our costs are still here. We're not onboarding clinical partners and new programs much sooner. It goes back to that list is not advancing from support. So their project behavior has to become more agile, but that is a tall order. I mean, health systems are not small organizations and not ones that are new. They have all been around for decades and decades and decades, longer than you and I have been around on this planet, right? In some cases combined, right? You often go into this massive system that are telling you about their 150-year history and all those kind of things. So those are organizations that are tough to change. And I think that as vendor community and standards community, we need to actually step into helping them go through that change through evolution, as opposed to launching every 3 years new revolutionary hype.
Mm-hmm.
Now that you have just figured out how to run your own data center, junk it, go to the cloud, and let's see how that works. Or just when you figured out how to fine tune your HL7 interfaces, forget about that. FHIR is the way to go, and deal with that, the rebellion in the ranks and all those kind of things. And one of the things that have universally been that I've observed with clinicians and clinical decision makers is the innovation change fatigue. Because they feel like they have to be seen as on a leading edge.
Yeah.
But then that comes with all kinds of heartbreak. And, we came up with the term bleeding edge for a reason, right?
Well, remember HL7v3, right?
Yeah. And the CDA adoption through meaningful use and we see that in paid transparency now. Like there's just a lot of those type of things where something gets pushed through without context and buy-in in a way, right? And then here's the situation.
Something you're touching on. So when I started out, we were talking about the adoption aspect of it. So you're putting in this, traditionally you put the box in and the interface specialist will do all the work in the background. And it's kind of done without the thought of the greater adoption of the users that are using it. Also, there's this aspect of the benefits realization. And I think there is a real opportunity to identify quantifiable, and I find many organizations focus on the qualitative benefits because those are very easy to grab. You ask a user how is it performing, and you either it's great or it's bad. But there is opportunities to really quantify, reduction in repeat imaging, reduction in turnaround time on reports, and so on. But those are all spoken about, but they take a lot of effort, and that does factor into the total cost of ownership of the solution if a provider really wants to go down that path and start quantifying and measuring benefits. But it reminds me of the Peter Drucker quote, "You can't manage what you don't measure."
Absolutely.
So thoughts on that?
I think we just need to borrow a very pragmatic approach that has made banks in particular very successful with their IT infrastructure. Keep in mind that most of them are still heavily relying on mainframes, and they have become mad scientists of the layered multi-generational IT infrastructure. And a reason very simple is that their thinking is all about ROI on IT spend. And of course, in banks' case, it's all per transactions per second and types of transactions and onboarding of programs and outreach to different audiences. But I feel like health systems should borrow from that thinking in terms of defining what those measures are, because there's only three that matter, right? First one is the encounter throughput, right? Encounter throughput over the capital and operating expense. So basically, if you undertake this 3-year strategic initiative or a 6-month project, are you going to see a needle move when it comes to how many patients you can serve in the same amount of time? So basically, is your monthly throughput the same or improved in terms of admits and discharges and avoidance of readmits and all those usual throughput measures, right? So we know how that works. The second one is obviously the clinical partners engagement. So referring physicians, external specialists, like imaging labs, physiotherapy, everything downstream, care coordination, and all that sort of fits into it. So are you able to recruit and retain more of primary care providers, more of specialists? And the third one is, of course, the good old operating expense, right? Are you starting to see movement on what you're getting for your spend, especially on shared services like IT and infrastructure, bundling infrastructure and everything else? And so that's, and to me, I think that sometimes in publicly funded or publicly supported health system that becomes anathemized because we are providing public service and all those kind of things. But at the end of the day, having an effective and efficient clinical operations is the best way for you to serve the community, right? Because no one wants a hospital that's bleeding money. No one wants a hospital that is not efficient in using resources. And I would say this is probably more important when there is public money involved than when the private money is involved, right? And I think that that's sort of, we should maybe move away from stigma of talking, oh, it's about, saving lives is much easier when you're doing it efficiently in financial terms. Because what that does is that you're allowing yourself to spend more on clinical research, clinical expertise, getting the best and brightest surgeons and specialists in your facility to actually then see those patients and spend most of their time on dealing with clinical cases as opposed to needing to get involved in all this other stuff. And I think that that's big part of the reason in defining those objectives are important. They're good, both in terms of qualitative and quantitative measures.
I'm going to give you one more question, and then maybe I'll also give you an opportunity to have some closing thoughts. But I wanted, if a provider was listening to this and they identify that, yes, we recognize we have some challenges, things do not work as seamlessly within our organization or even across organizations as we'd like to with access, and we could go on and on about the myriad of use cases. What would be your recommendation for them to start out, and what would you propose to them to start their journey on looking and assessing where they should go from here?
So three things. First is really understand and quantify your care delivery bottlenecks, what those are, and how do you measure that they are a problem, right? Because going back to measuring success, the measuring failure is the same applies. Is this really a problem? Or is just someone who is a cousin of your neighbor that's complaining to you over a barbecue on a Sunday, and then you go back to the hospital and raise hell? Like, I think there's that element. So quantify the challenges and rank them, and then look at additive, evolving technology solutions, right? Do not touch your EMR. Do not touch your integration engine. Do not, for sake of everything that's good, do not touch your archive and VNA and PACS. Think about ways to leverage interoperability investment by all those vendors, which is not insignificant over the years. And the first thing to start with is look at intelligent automation. In my mind, I think that some of the projects that I was involved in COVID years, as I started doing more independent consulting, were eye-opening as to how that can work and how quickly it can create stunning results for clinical workflow. And I think this is not sort of this agentic AI, esoteric, future vision. No, this is happening today. Hospitals are able to process more claims, schedule more patients, see more patients, and not lose clinicians because of admin work. It's happening today, and that's the starting point. It's a very simple thing. And then start layering in the integration components, which a lot of these platforms have already, so cross-integrate. And then, technically, I think it's time for us to start looking at agentic integration interface development, right? I think that's something that is coming, no question about it. It's a big word, it's a hype word, so we have to be careful. But I think understanding what you, the facility, want out of it, and then, just go to the field and expect someone to deliver results to you in 6 months, not go through a 3-year strategic, this and that, the other. I mean, you already done that. So start small, expand, solve bottleneck by bottleneck, and it can be done in a rapid fashion.
Yeah, I think that's a good point, is that despite these buzzwords and these hype cycles, it doesn't mean that these aren't real. So, agentic AI is going to be something that really allows us to help with this automation. It's just, as a provider or as a purchaser, be wary of the marketing versus the actual.
But this is where the conversation, and I think that maybe is a good closing thought as any. The conversation between a buyer of interoperability and automation and all those components and a seller has to change into, I want this outcome from these technologies. Can you do this for me? And this is where all the vendors also need to rediscover their own partnerships where, okay, it takes a village to solve some of these problems. Build a team, build a partnering team. Don't just go and sell your stuff and bounce, right? Mm-hmm. That is not going to benefit anyone, including your own shareholders, in about a year's time. What you want to do is to change that conversation to say, as an organization are solving this challenge, we feel, or we know based on, consultants assessment or whatever, however you get there, we understand that these are the pieces that we need: agentic AI, API integration, cloud storage, whatever, SD-WAN, whatever is in the mix from our assessment. But then that conversation needs to be more collaborative in the sense of, okay, here's how we're going to do it. And here is a product 1, product 2, product 3, product 4, and some of these options. And it benefits everybody. That provider gets better results for their money. And then all the vendors involved in that type of approach. And I've seen this time and again, when you shift sort of your sales and marketing posture into that mode, is your deals become faster, they are better foundation for growth, and they produce better margin and recurring revenue. So everybody wins, including the patient that then now benefits from more clinical attention to them.
I think that's a great way to end. We've given the providers something to think about, and we've given the vendors something to meditate on as well. Thank you very much, Toni. I really appreciate this conversation. I don't think this will be the last time we chat. We can have you on some other time down the road.
Yes, many things to dive into. I appreciate this, Jason. I think it's an important conversation, and I thank you once again for creating forum for it.